So we will start now in earnest with Dr. Sarah Henderson. In planning this conference, Sarah always plays a key role, and I'm always so thrilled to hear from her because I learn something every time. And that's a common thing to say for speakers, but for Sarah in particular, I'll say it's incredibly true. I even go back and look at her PowerPoint slides sometimes, and it's I don't often do that, but I do, and pick out incredibly insightful information. Today she's going to talk about, as you see in your program, extremely hot and very smoky, the changing face of summer in BC. Sarah is the scientific director, thank you, of the Environmental Health Services at BC CDC. Also the scientific director of the National Collaborating Center for Environmental Health, and also an associate professor at the School of Population and Public Health at UBC. And she bridges those worlds masterfully. She's, to me, a quintessential applied environmental health researcher. You'll see that not only today, but just if you observe her over the years, a true role model for me in how to apply this science to the real world and translate it meaningfully. And so I'm going to ask Sarah to come up and get started. I'm hoping, good, slides are right there. This is for you.
Thank you very much. I'm going to feel like I'm blushing right now because that was such a complimentary introduction. So, wow, it is just so nice to see familiar faces and new faces all in the same room. This is one of the first times I've been in a public space like this since the beginning of the pandemic, and it just feels wonderful. So welcome, everybody. As Chris said, I do want to talk to you about the changing face of summer in British Columbia, and I'm taking a real focus on British Columbia here, partially because we are, in some ways, a bellwether for climate change. I think we all experienced that in 2021 with the heat dome, the drought, the wildfires, the flooding. A lot of climate-related disasters happened packed together for us. And partially that position as bellwether is our geographic position in the world, and partially it's due to our topography. So while climate change globally is an important topic, I really am going to focus on the BC context here. Climate change is no longer a scary thing that's going to happen in the future. Climate change is a scary thing that is happening right now, and I feel the conversation shifting that way. As someone who's been working at the intersection of climate change and health for 20 years, I'm really glad that shift is happening. It's coming a little bit late, but I encourage everybody in this room to talk about climate change as what is happening to us right now, not something that is going to happen in the future. It's going to continue to happen in the future, but we are there now. These are the different projected trajectories of temperatures in British Columbia under different representative concentration pathways, which is the language that the IPCC uses when talking about climate models. The red pathway is the worst case scenario. We don't get emissions under control. Let me assure you, as a global community, we are on that red path right now. So in the absence, at this point, of real global effort to reduce emissions, we do need to anticipate that that red path is the future that we are moving towards. I'm real fun at parties. It's also, and this comes kind of back to what I was saying at the beginning, this temperature isn't sort of equally distributed across Canada or British Columbia. These changes are happening very rapidly in the north of Canada, rapidly in the north of British Columbia, less rapidly in the South Coast area where most of us find ourselves. Now, if you think back to 2021 and you think, wow, those changes are less rapid here than they are elsewhere, Just try to project in your mind what's being experienced by people living in our northern, rural, and remote communities. These data come from PCIC, or the Pacific Climate Impacts Consortium, and it's a bit telling that PCIC, in their plan to adapt tools, are really now only showing the projections for representative concentration pathway 8.5, or that kind of worst case scenario pathway, because they have decided that that is the pathway we're on, and those are the projections that we should be showing. This shows typical summer temperatures in June, July, and August across BC many years ago now, compared with what's projected towards the end of the century. You can see that these increases in temperatures are not uniformly distributed across the province. It's going to get hot in our mountain valleys and along the south coast. Those places where it's getting really hot are the places where most of the provincial population lives. This is a different way to show it, but I like showing it this way because it's scary. This is cooling degree days, so the difference between 18 degrees, or a comfortable indoor temperature, 18 is arguably a bit low, and the actual temperature multiplied over the number of days that might occur in a given summer. And what it's telling us is that we need to do a lot of cooling in areas where people live to keep indoor temperatures comfortable and safe. Just move over to precipitation here for a bit because it's relevant to drought and drought conditions and wildfire conditions. So this is total winter precipitation as snow, again, some time ago, and projected towards the middle of the century in this case. And you'll note that we're not even getting snowfall around Vancouver Island in those coastal areas. It's nothing but rain. So we're going to see a real shift away from snowpack to rainfall, and that has implications for our water supply and for our drought conditions in summer. And then if we look at summer precipitation, which we would expect to come as rainfall, we are seeing increasing drying through the dry mountain plateau and along the coast. And I like to move on to this slide because, again, I'm not going to lie to you, that's a lot of really scary stuff. This shows habitability across the world in 2070 versus 2020. 2020 is not that long ago. Canada is looking pretty good compared with a lot of other places in the world. It is not going to become less habitable, less suitable for habitation. It's going to become more habitable. So we also are going to face this increased pressure of people wanting to move around the world to get away from less habitable places into more habitable places. So now I want to flip into the scary writ large into scary writ small. The 2021 heat dome was one of the most intense heat events ever recorded on the face of this planet. It was catastrophic, and at the same time, we are incredibly lucky that it lasted for a week and not for 3 weeks, like some of the events that we've seen elsewhere in the world, recently in South Asia, for example. If it had lasted for 3 weeks, thousands of people would have died here, in the same way that thousands of people died in Europe in 2003, in Russia in 2010. So we did not have good outcomes during this event, but it's very important that people be clear, it could have been worse. In general, we were experiencing temperatures that were 15 to 25 degrees above seasonal norms and 5 degrees higher than had ever been measured in most places in the province. This was, when we use the word unprecedented, this was truly unprecedented. Hundreds of people died. Don't get me wrong here. This is a plot that shows daily deaths in BC. Those green bars are normal days. A pretty predictable number of people die in British Columbia on a day. It's about 110 with a standard deviation of maybe 20. That allows us to model how many people we would expect to die on any given day with pretty good accuracy. That's that black line you see across the bottom of the plot. And then we can measure what we call excess mortality, which is the difference between how many people actually died and how many people we expected to die. Those orange and red bars are days when deaths were statistically significantly higher than we would expect them to be, and they show the excess mortality associated with the acute phase of this event. There were about 740 excess deaths over that 8-day period. And there's a couple of features that's important for you to look at here. Oh, no. No. Oh. Go back. There we go, thank you. What I want is a, yeah, but I don't know how to make it happen. Okay. I'm just going to point here. I'm going to stand and point. Oh, how?
It's the top.
That top one.
Yeah.
Ah, there we go. One of the key features of this event, you can see these are the population weighted average temperatures, so kind of the temperature experienced by the whole population. Peak temperature was on June 28th. Peak excess mortality is on June 29th. This is very typical. We usually see deaths follow temperatures by about a day, and that is because people don't die because it's hot outside, people die because it's hot inside, and those outdoor temperatures are translating to build up in indoor temperatures. I'm going to talk a lot more about this. So again, we estimate about 740 excess deaths associated with this event. It's a little bit different from what you've been hearing in the coroner's reporting data, and I know that's a bit confusing, so I just want to outline for you why those differences exist. Not every death gets reported to the coroners. In general, there's usually kind of 25 to 30% of deaths that happen on a given day are reported to the coroners for investigation. During this period, we had 54% of deaths recorded to the coroners, so that's a pretty significant increase for them in investigations, but it still means that 46% of deaths were not reported, meaning that the coroners did not investigate them, meaning that those deaths never had the opportunity to be called heat-related, even if they may have been heat-related. So there's just a little bit of discrepancy in the numbers here. I want to give a huge shout out to our coroner's service. I don't think that an extreme heat event has ever been as well investigated by a coroner's service as this one. The fact that we have more than 600 of those deaths attributed to extreme heat is amazing. These deaths were not uniformly distributed within the population. Now, we often hear that older people are most at risk of death, and I think there's the misconception that this is something that affects the very elderly. In absolute terms, certainly the highest number of excess deaths was in the elderly, but in absolute terms, the most deaths on any given day are among the very elderly. So we do need to look at these proportional differences. And what we see here is, a fairly minimal effect on people under 50, but in absolute terms, among the very elderly, but overall, we have almost a doubling of mortality in all of these age groups over 50. So this isn't something that only affects the very elderly. This is something that affects older and middle-aged people, because I'm getting pretty close to 50 myself, and it's important that we not ignore the risk to those potentially younger people as well. The bigger story in some ways is this. You know, after the heat dome, there was a lot of talk about long-term care and residential care and the impacts, and that's absolutely correct. We should be protecting people in those environments, but overall, that's not where people died. We did have, slight increases in mortality in those environments. Most of these people died in the community in private residences. That's perfectly consistent with what the coroners have reported. This is from the hottest week of the heat dome. There were 526 heat-related deaths according to the coroner's review, and of those, 506 of them happened in private residences. So go back to this incredibly important issue. People don't die because it's hot outside. They die because it's hot inside. These are data from the Abbotsford International Airport. That's this black line here. And then from a home in Abbotsford that has central air conditioning and a home in Abbotsford that does not have central air conditioning. There's a few key features we need to talk about here. This place is fine. I would love to have been there during the heat dome. These are nice, safe temperatures, very low variability over this period. This place is hot to begin with. There's no air conditioning, and then as the peak temperatures climb day over day during the heat dome, they climb indoors in this environment so that we are looking at a peak temperature of 40 degrees on this hottest day in this home. That's the thing. This is the reason so many people died that next day, because they go to bed at night, it is extremely hot. A lot of people died in the night, and then they're found the next day. Couple of other things to consider. First, this peak temperature outdoors is usually happening around 5 or 6 p.m. at this time of year. Remember, this is right after solstice, so we're talking about peak daylight hours. This indoor temperature is happening a few hours later, so it is hottest in people's homes when they're going to bed at night. The heat accumulates during the day. Finally, if we look at these overnight temperatures, a very high overnight temperature for this region. It is almost 25 degrees, almost unheard of. This is a safe temperature from a human health perspective. I think there is often the misconception that a house is going to normalize to the overnight outdoor temperature overnight. That does not happen. You can see this house loses a few degrees, it comes down to about 33, and then starts to go up the next day. This is the problem right here. I've drawn this line on here because there's new work from Glenn Kenny's group, and Glenn should be here. There he is. Glenn's going to be talking later today about safe indoor temperatures. Now, the guidance is under 26 degrees indoors. That's pretty safe for most people. Once we get above sustained temperatures of 26 degrees indoors, it's starting to get risky for the more susceptible population. Once we're above 31 degrees indoors, it's to sustained temperatures, that's getting dangerous for susceptible people. And you can see this home was a dangerous place to be if anybody susceptible had lived there. The deaths did not end when the heat dome ended. I haven't talked about this too much publicly yet, but I just want to show you a few things to demonstrate this. So here's deaths due to respiratory infections, including COVID-19. We've got a bit of a wave here. This is the intervening period between the heat dome and the Delta wave of COVID-19, and you can see deaths from COVID-19 are very low during this period. These are deaths due to external causes, illicit drug toxicity, and other unknown impending causes. They jump up right away, this has been truncated, and then they stay high. Some of these will resolve over time, so we don't want to read too much into this. But here's where the real story is. Deaths due to heart disease are pretty flat coming into this heat dome. They jump up at the heat dome, they stay high, and they stay high. after the heat dome. This looks fundamentally different from this, and we see the same pattern in dementia. With dementia, there may be some cross-contamination by COVID-19. It's possible that someone with dementia would be infected and succumb to that infection without anybody realizing that they were infected. That's sort of less possible here. Frozen again. There we go. Looking at this in another way, we talk about cumulative excess mortality. So now we're just day over day adding up the excess deaths that happened in the population. And this is the cumulative excess mortality starting in January. This is the heat dome, and these are different age categories. So taking the example of the 60 to 79 year age category, there was excess mortality accumulating until we got to the heat dome. Big jump at the heat dome, and then more accumulation. If we had followed the pre-heat dome trajectory, we would have gone like this. You can see these lines are close to parallel. This one has a slightly higher slope. However, if we look at the 80 plus category, this was pretty flat coming into the heat dome, and if we'd retained that trajectory, we would have gone this way. Instead, we jump up, and then we go up and up and up. We see a similar pattern when we look at this by the health authorities in the province. So similar type of plot. If we look at Fraser Health, it was going up, big jump during the heat dome, and then slight deviation from this trajectory. If we look at Interior Health, pretty flat coming into the heat dome, bit of a jump, and then up and up and up. So clear evidence here that that heat dome and its impacts on deaths did not end when the temperatures decreased. We've been doing a lot of work to try to understand what happened during this event, and I'm going to move through it relatively quickly because I want to ensure that A, we get back on schedule, and B, that we have enough time for questions at the end. The first thing we did was look at communities where people died at home rather than in long-term care or hospitals. We did this restricted to the Greater Vancouver area, so we compared 434 deaths that happened in the community during the heat dome with 1,363 deaths that had happened in the community around the same time of year in previous years. So we're comparing people who died with the heat dome with people who died at that time of year in other years. That's our comparison. This thing and I are not friends. There we go. And if we look at the ratio of the heat dome deaths to typical weather deaths by local health area in BC, we see some real differences strike out. First of all, that really red area is New Westminster. If you're not familiar with New Westminster, it is on the south slope of the Fraser River. It gets a lot of hot sun during the day. It's also a place where there's a lot of affordable housing in older buildings and where a highly susceptible population may live. So it was the most impacted region of BC. Then we see some darker orange areas in East Vancouver, in Burnaby, out in the Fraser Valley, and light yellow areas more so along the coast where the temperatures were somewhat lower and there's a bit of protection from the coastal offshore breeze. Where should I be pointing this thing to make it do what I want it to? Like, where's the receiver for it?
I don't think it's you. I think you're often delayed in a very annoying way. Do you think it's just a delay or not?
I don't know.
Maybe it's your delay.
When we look at this on a community basis, we find, compared with areas that have normal material deprivation and normal material social deprivation, almost no impact in those privileged areas that have high material privilege and high social privilege. When we look at areas with material privilege and social deprivation, we do see a bit of a risk, 50% increase, not statistically significant. But when we start looking at those areas where there is high material deprivation, and especially high material deprivation and high social deprivation, we're seeing a 100% increase in risk, a 200% increase in risk. This event did not have a proportionate impact on the population. It was highly disproportionate and highly skewed towards people with low socioeconomic status and probably people who are more socially isolated. The other thing that we found is that green space was still significantly associated with death during the heat dome, even when we account for deprivation. So we know that highly privileged areas have more green space than less privileged areas. What this is telling us is green space is still protective in less privileged areas. Now, this was measured with the NDVI, which is simply a satellite measure of how green things are. Doesn't mean that we can go out and paint things green and everything will be okay. So we also want to look at this in a more policy relevant sort of way, and that is looking at the same question with the tree canopy coverage across the city. If we increase the tree canopy coverage in this study within a 100-meter radius, decreases risk by almost 10%. And that 100-meter radius is important. That's the only radius that showed up as important in our analyses. We looked at 30-meter radius? No. We looked at a 1-kilometer radius? No. It's that 100-meter sweet spot that really mattered. The second analyses that we have done are related to comorbidities that were associated with death during the heat dome, and this is quite a similar structure of analysis, but now we're not focusing on people who died in the community, we're focusing on everybody who died during this 8-day period, and we've split them into people who were potentially heat-related deaths. That means the coroners still have the death certificates and have not yet submitted an official cause of death. There's 683 deaths in that group. And people who did not die specifically of the heat. They have another code on their death certificate. There's 929 deaths in that group, and we are comparing them with the same time of year again in previous years. First thing I want to point out is how these people look in the health system matrix. This is a tool that the province uses to understand what the health system is going to cost in upcoming years, and it categorizes people into things like low user and non-user, low chronic morbidity, medium chronic morbidity, and it's simply to assign a dollar value to people and to make estimates around what the system as a whole is going to cost. But it provides some helpful information for us here. So first of all, in these potentially heat-related death groups, we have a very high proportion of non-users compared with the other group. This may indicate a very healthy population. Seems unlikely. It probably indicates a population that's quite socially isolated and actually doesn't get out to use healthcare. We also see a higher proportion of low users in this group compared with this group. They're reasonably balanced here. Indeed, there's sort of less high chronic in this group than there is in this group. This is the striking thing. Severe mental health and substance use disorder. We got 10% of the people in this group here, only 1.5% here. And when we do the statistical analyses with all that, we see it play out in the data in a striking way. So these are a little bit small, and I apologize for that, but I'll walk you through them. At the top of the list here, we have schizophrenia. In the potentially heat-related deaths group, we have about a 2.5-fold change in risk for people with schizophrenia. But even if we look at the non-heat-related deaths group, we see this increase in risk for people with schizophrenia. This goes back to what I was saying earlier. The coroners didn't investigate all of those deaths. We do know that there were 740 excess deaths, so we do know that some heat-related deaths are tangled up in this group. Well, some of them had schizophrenia. When we look at depression, we see in the potentially heat-related group a big impact, not so much in the non-heat related group, and then substance use disorder is the same. We see in both groups an impact of diabetes. That's not surprising. And then we go down through a bunch of conditions that did not have a statistically significant impact. And down here, we come to a bunch of conditions where there was a statistically lower proportion of individuals that died during the heat dome compared with individuals who normally die. And there's a lot of these that are related to heart disease, and then at the very bottom, the one with the biggest negative impact is dementia. And we would hypothesize here that people care for people with dementia in general. They've got eyes on them during an event like this. People take special measures to protect them. So the themes that are coming out of this, we have risk factors, clearly indoor heat, clearly severe mental illness, very likely social isolation, clearly substance use disorder, if not specifically substance use at the time of death, material deprivation, diabetes. Protective factors, indoor cooling, privilege, green space, social connection, being in care. I hope this is starting to paint for you a stark picture of the types of people who are at risk during these events. Time to switch to wildfires. So as the heat dome broke down, these were extraordinary meteorological conditions. They left a lightning storm behind them, and that lightning storm lit up the wildfire season in the interior of the province into one of the most manic wildfire seasons I can remember in the interior. The area burned maybe wasn't as large as 2017 and 2018, but there were a lot of evacuations. There were a lot of close calls in some of our large communities. It was quite a season. Obviously, the loss of the town of Lytton at the very beginning of this season is what's going to remain in people's minds. It's one of the first times we've lost a whole town to wildfire in BC. Unfortunately, it won't be the last time. I think we all probably know that. Again, this is just the state of evacuation alert and evacuation order. The alerts are in orange, the orders are in red across the province on one bad day in BC. They're everywhere. This was not the smokiest season of all. Really? No. Not the smokiest season of all time, because it was so windy, which was one of the reasons why the fires were so intense. So we didn't see that sort of huge accumulation of smoke across the province that we've seen in other years, but there was a lot of wildfire and certainly some smoke impacts in the interior. I want to turn back and look at September of 2020 here. This is one of the more memorable smoke events in recent history. This wasn't our smoke. This was smoke from California and Washington and Oregon, but it got blown up into BC across the border for about a 2-week period in September 2020. Smoke knows no international boundaries. And one of the things I always try to get people to think about when we're in a meeting like this, especially if you live on the South Coast, is this was pretty awful. I mean, people remember how bad this was. I just want to talk to you a little bit about what it looks like in the interior and the north when we see these types of smoky conditions in the south. So these are 5 years of smoke in the Vancouver area, starting in 2016, not a bad year, 2017, record-setting year, 2018, record-setting year, 2019, not a bad year, 2020, this long-range for transport of smoke. So there's, we see the impact in 2017 here. We see the impact in 2018 here. This was orange skies and, it just looked wild if you were here and you remember. And then, we got socked in again here. This is the same time period in Kamloops. So if we go back again, just entertain me just put that in your mind. We're looking at concentrations of maximally about 125 micrograms per meter cubed here. Again, here's what it looks like in Kamloops. So we're looking at concentrations around 200 here. They're lasting for weeks, a little bit less in the summer of 2018. There's that summer of 2020. And this is Prince George. Similar type of thing, but summer of 2018 was a real doozy up there. So, just remember that when we're experiencing smoke here, somewhere else in the province, it is generally worse. We often get, well, who's most susceptible to smoke? Absolutely anyone with asthma or chronic obstructive pulmonary disease. That's why we've worked so closely with the BC Lung Foundation on this topic for so many years. If you have a reactive airway disease, smoke wants to close your airways. It makes it difficult for you to breathe. I call these folks the canaries in the coal mine. But anyone with heart disease, diabetes, dementia, mental illness, older adults, pregnant women, infants, children, outdoor workers, marginalized groups, all those people are going to be more susceptible to smoke exposures when they occur. We did some work a few years back to say, well, okay, how many susceptible people are there in the population? If we define it as narrowly as possible, 33% of the BC population is potentially susceptible to negative health impacts from wildfire smoke. It's not a small proportion of the population. If we broaden it out to the outdoor workers and other marginalized groups, it's 66%. So, everyone is at risk from these exposures, essentially. Chris likes this slide, I know. This is just to help people understand what we expect to see on a smoky day in the province, where I'm defining a smoky day as 100 micrograms per meter cubed of PM 2.5. And on the left-hand side of this plot, we have respiratory outcomes, and on the right-hand side of the plot, we have cardiovascular outcomes. The blue lines show medications, the red lines show physician visits, the black lines show deaths. And on the respiratory side, we can see that all of these things are elevated. Some of the confidence intervals are wider. But in general, we, expect about a 70% increase in all of these outcomes in a smoky day in the BC population. We still see increases in the cardiovascular outcomes, but they're much, much smaller. So it's not that there's no cardiovascular risk associated with smoke, but the respiratory risks are the primary risks. Now, most people spend the vast majority of their time at home or inside. This is an old study now, but it's still very relevant. I doubt this has changed much since the study was published. Here we have in Canada and the US the amount of time that people spend indoors or in their cars versus outdoors. Sort of sad. I love being outdoors, one of my favorite things, but this is actually probably pretty representative of me as well. So, either everybody is experiencing these health effects from wildfire smoke in the 1 to 2 hours a day they might be outdoors, or the true effects of wildfire smoke are being underestimated because it's actually the indoor concentrations that are driving them. And I'll explain what I mean a little bit more here. But it's very unlikely that these health effects are only happening in that small proportion of the time people spend outdoors. Smoke gets indoors, people are exposed indoors, and they have their health effects, probably 94% of them, indoors. This is another older study from our colleague Prabjeet Barn. I don't know if Prabjeet's here today. Oh, hi Prabjeet! Who, prior to doing her PhD, went out and measured smoke in people's homes in the province with and without an air filter running in their homes. And if we look at these black lines here, these were the infiltration of PM 2.5 when there was no air filter running. So if we're at 1 here, it means that it was just as smoky inside as it was outside. And down here, we've got, about 30% of the smoke getting indoors. On average, about 60% of the smoke got indoors across these homes. And that's very typical of other measurements in single-family dwellings. So now we have to reframe what we just talked about is a very smoky day. A very smoky day outside is 100 micrograms per meter cubed, but if we apply an infiltration coefficient of 60%, a very smoky day inside is 60 micrograms per meter cubed. That means that these effects that we see are not actually associated with 100 micrograms per meter cubed. They're actually associated with 60 micrograms per meter cubed. Smoke is when we look at the outdoor concentrations as a proxy for the indoor concentrations, we're actually underestimating the true impact of the exposure. A little bit more about smoke infiltration into buildings, and we're going to talk about that a lot today. Larger buildings do better in general. This is a study out of Australia where they were looking at a library as a potential to offer cleaner air shelter. And when they had no HEPA filters running, there was about a 30% infiltration. That's on the low side of normal for larger buildings, but fairly typical. We did a study at GF Strong a couple of years ago. This is during that 2020 event that was caused by smoke from fires elsewhere. We have low-cost centers located throughout the building, main floor, basement, 4th floor, and then one on the rooftop. I hate this thing. I loathe it. Can somebody advance this slide for me, please? Pardon? The whole presentation froze? I see something moving. Thank you. So here's the rooftop sensor during that event. Pretty normal air quality until we get to the smoke starting. A couple of days of smoke, it drops down again, and then smoke, 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 smoke. Concentrations here around 150 micrograms per meter cubed. And then when we look at the 4th floor elevator, this is what's getting indoors. You can see it tracks pretty directly, but we've only got about 50 micrograms per meter cubed getting indoors, a little bit more here in the ground floor lobby, and somewhat more near the basement elevator. This is right by the loading bays of the building. So on typical days, the infiltration of PM 2.5 ranged from about 18 to 39%, and during the smoke episode up to about 50%. This is, if you're not familiar with it, a large inpatient facility where we would expect a lot of susceptible people to be living, and to be living 24/7 while they are recovering from a wide range of severe injuries and facing a life, in most cases, of significant disability. So, we have to consider these healthcare facilities as a particular environment of interest for these exposures. I've been working with ASHRAE, a couple others in this room might be on that committee, and trying to develop some guidance for building operators around how to smoke ready a building, how to create a plan, how to work with HVAC technicians and others to think about keeping smoke out of these environments, to keep people safe in these environments. We were able to put forward this sort of preliminary guidance document last year, and the full guidance document should be coming out in the year ahead. Final thing I want to talk about is these events do not happen in isolation. We can have extreme heat and very much smoke all at the same time. This gets complicated when trying to communicate with people about their risk. It can also happen during a pandemic, as it turns out. So we're getting into a really complex world where we've got a lot of complex and competing, co-occurring public health risks. This is a tough one. but I'm going to stack up the bodies as a way to think about it. So on extremely hot days in BC, there may be 100 to 300 more deaths than we expect. On extremely smoky days in BC, there may be 5 to 10 more deaths than we expect. We very strongly recommend that people seek cooler, cleaner indoor air as the best way to protect themselves against this kind of combined event, but please prioritize cooling. It is the bigger threat to health for most people. When I say most people, those people with very reactive asthma or very reactive COPD are going to be highly at risk from both of these exposures, but it may be those smoke exposures that are more important to make sure they're protecting themselves from. Just to set up the rest of the day here, the indoor environment is an incredible place. We spend a lot of time there. It has the ability to protect us from these changes that are happening in the environment around us if we design it well. It also has the ability to harm us if we don't design it well. The case of indoor heat being primary in my mind. We had houses that simply acted as greenhouses during the 2021 heat dome. We had people reporting indoor temperatures of 56 degrees. That's actually not a livable human temperature. So we need to think very carefully about this complex indoor space to ensure that it is helping to protect us from the complex outdoor world. That means thinking about temperature. It means thinking about air quality. It means thinking about moisture and doing our best to create an environment that balances all of these things in a healthy way. So thanks very much for your time. No thanks to you, little gizmo, and I hope I have a little bit of time for questions here. Oh, standing ovations! Chris forgot to tell you this. We always give standing ovations to every speaker. I'm not just doing this for me at this event. So everybody, please stand up and clap for me.
Bring it on. There's microphones. Okay. As people come up, I want to ask, I hope I didn't miss it, but you were trying to figure out why the cardiovascular related deaths stayed high for months after heat dome. And I think I was on my computer because I was taking notes, but I was also paying close attention. But you haven't really figured it out, right?
Well, and Glenn may be able to speak more to this when he's up here, but, a death due to extreme heat is a death due to a preventable injury. And that injury that occurs during extreme heat may not be fatal in some cases. So my hypothesis would be that the heat dome caused cardiovascular injury and brain injury in individuals who were susceptible during the heat dome, particularly those who were older, and they succumbed to those injuries in the weeks that followed. Does that sound about right, Glenn? Yep, okay.
All right, that's a good concept, I believe. Okay, please.
Thank you for a great presentation, Sarah. I found it really interesting when you were looking at the dispensation and the hospitalization, and you went indoors and changed it from being based on 100 micrograms per meter cube to 60. And then my question is, would you not expect it, do you think that there's a level at which you don't see a sharp increase anymore in deaths? Right?
Yeah.
So I'd just be curious as to what your thoughts are on where that is. Because, of course, our ambient objective is 25, right?
You've set me up so perfectly. Thank you. We've been working on an opinion piece on this topic because I think people get really excited and worried about wildfire smoke when the skies are orange. We need them to get excited and worried at 25 micrograms per meter cubed. And that's a really hard thing to communicate when we're talking about knowledge translation, because people expect that the skies are orange. It's way worse for them when it's a little bit smoky outside. That is absolutely not true. The shape of this curve is steep, 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 flat, 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 flat. That flattening starts at about 100 micrograms per meter cubed, so that very smoky day I was talking about. But if we add up the hospital visits, the deaths, the dispensations, the biggest impact is actually in the 25 to 50 microgram range, because we experience those kinds of concentrations far more frequently, and there's quite a lot of health effect in that range. So the shape of that exposure response curve is really important, and we do have to learn how to communicate about it a bit better. We do a bit of that with the AQHI, which sort of ends at 10 plus, but I think it's one of the places we need to go when we're talking about smoke exposures. I would have heard you.
So, Sarah, you mentioned mortality numbers in the community versus healthcare. Is it statistically significant, though, how many more people are in the community versus healthcare?
Oh, that's a great question. You're getting me on my own question of proportionality here. I don't know, if we look at the BC population, what proportion of the population would be in acute care or long-term residence compared with the entire population. I suspect it is disproportionate when we think about it that way. I can't answer that immediately, but I can say if you're in acute care or if you're in long-term care, you are highly susceptible to those exposures, right? So I would expect some disproportionality in the distributions of deaths that way.
Okay, so I want to ask a question because I don't see any others. I want to use the microphone just because I hear there are people online.
Oh,
Sorry.
yeah, okay.
So for people online, and also if there are questions from people online, I have no access to them, so someone will have to tell me, and Men is going to do that. But I'm going to ask this, although she did not ask me to do this, I'm going to ask it anyway on behalf of Dr. Emily Brigham, and it'll make sense why in a second. Emily's a new faculty member, very much onto this theme, and she has been talking about an action plan, a heat-related action plan for individuals, which is a little with healthcare provider guidance and support, which is different than the awesome, and I mean truly awesome, BC CDC material that one can get from the internet and whatnot. I just want to ask you, Sarah, and I know this is not a forum that's necessarily healthcare predominant per se, but what do you think about developing a system where an action plan can be tailored to individuals with a healthcare provider, kind of personalized so that they're ready for and ready to be supported for a heat-related event, much like we do for other things, but I don't know has ever been done for heat, but maybe it has.
So, Chris, I think you know this is a pet issue of mine, and for any clinicians in the room, my ideal world is one where people's family doctors speak with them about their heat and smoke exposures and what those exposures might mean to their health you're so tall. What those exposures might mean to their health in a very personalized kind of way, engaging not just physicians, but nurse practitioners, midwives, massage therapists, the whole allied healthcare community in the conversations about climate and health is going to be critical for communicating with individuals in a way that they trust. People trust their healthcare providers. If they're getting this information from their healthcare providers and in partnership with their healthcare providers, they're going to take action in a way that they're not if they read a document on the BCCDC website. Our documents are great, though.
They are. Okay. We can squeeze one in, or I can say amazing job getting us back on track.
Yeah, that's fine. No, you folks know I like to run a tight ship.
Don't go too quickly.
Okay.
I have no idea what's in here, but I'm sure it's awesome.
Okay.
Thank you very much.
Thank you very much, everybody.